and I'll kind of talk about the DLCO again. And of course, if you're doing any type of challenge testing, like a methacholine challenge for asthma, you definitely want to be in a PFT lab. So this is talking about those static lung volumes, and just really briefly, as you're listening to my lecture, hopefully you're just kind of easy breaths in and out. You're having just tidal volumes, tidling. And if you take a deep breath in, that's inspiratory reserve volume, deep breath out, expiratory reserve volume. And if you add up all these volumes together, you get a what? Capacity. So when I add up my inspiratory reserve volume, tidal volume, and expiratory reserve volume, that gives me the vital capacity. And if I want to talk about restricted diseases, I need to add my residual volume to my vital capacity in order to get TLC. That's what really defines a restrictive disease. Now this is showing spirometry. So this is probably the thing I would really try to understand the best of all these things. So let's look at normal. So when we talk about spirometry, it's about blasting it out, obstructive lung diseases. So someone is probably going to be tidling in, out. Take a deep maximum breath in, and that's going to be TLC, total lung capacity is the end of a maximum inspiration. And what do? Blast it out. So if you have an obstruction on expiration, then it's going to take, you're not going to blow out as much volume. It's going to take longer for you to blow it out. But looking under normal, this is what happens. The FEV1, this is how much volume you're blasting out. Then they tell you to keep on blowing all the way to the end, more. And at the end of that expiration, it's going to be our vital capacity. And if I tell you to blast it out, it's called a forced vital capacity. So when I look at the obstructive, graph and compare it to the normal, notice that TLC is slightly elevated. In the setting of obstructive lung disease, an elevated residual volume and TLC implies air trapping. And then look at the FEV1. They can't really blast out any volume in the first second. They're really obstructive. And it takes them a very long time to get to the vital capacity. And that's why when we encourage people with COPD to breathe, they do something called pursed lip breathing to try to get all the air out. And look how much residual volume is left in here. And it's because of this residual volume that when you shoot an X-ray, they have the flattening of the diaphragms, that barrel-shaped chest that can happen. And that's why the FEV1 and FVC is low, because of such a high residual volume. Now, when you look at restrictive, sure, the FEV1 and the FVC are low because the lungs are small to begin with. Small lungs, less volume. But, when we talk about, there is no obstruction there. And that's why we can't use just the FEV1 and FVC to diagnose restrictive diseases. You need to have that total lung capacity to really say it is restrictive. Now, this is the DLCO, and if you look at the right top of your screen, I kind of like this picture a bit. This is looking about when I say a gas, and in this case, we're talking about carbon monoxide. We give it to the patient, and that carbon monoxide should diffuse freely into the capillaries. It needs to diffuse through the alveoli, through the interstitium, and end up in the capillary. But if you have damage in the alveoli, let's say you have obstructive lung disease, atelectasis, of course, a DLCO would be low. In the interstitium, let's say there's fibrosis there, you're going to have a low DLCO. In the capillaries, let's say you have a vasculitis or you have pulmonary hypertension, sure, there'll be thickening of the capillaries and there'll be a low DLCO. And are there times where the DLCO could be high? The answer is sure. I know that some of us memorize things like polycythemia and alveolar hemorrhage. Those are all correct, but to keep it simple, anytime you increase blood volume or RBCs in the area of the pulmonary capillaries, well, it's going to be falsely elevated. Why? Because when you give carbon monoxide, who really picks up the carbon monoxide in the capillaries? Yeah, that's right. It's the hemoglobin. And does hemoglobin like carbon monoxide? Yeah, totally. It loves it. So anytime you have more blood volume, blood contains RBCs, it contains hemoglobin, sure, more carbon monoxide will get picked up. Bottom line point is, correct the DLCO for hemoglobin. It's just a concept you should be familiar with. So bottom line point. So TLC is for what? To assess restrictive diseases. less than 80% predictive is abnormal. The ratio is to assess obstructive lung disease. Less than 70% predicted is abnormal. And DLCO tells me how much oxygen is going through the big three: alveoli, interstitium, and into the capillaries. You need all those three to come up with an interpretation of your PFT. So with that being said, I have a 60-year-old woman is evaluated for a 4-month history of progressive fatigue and dyspnea on exertion. She does not smoke cigarettes, denies chest pain, palpitations, dizziness, or syncope. She has a 12-year history of limited scleroderma. Stop right there. So when we talk about systemic sclerosis, we talk about limited scleroderma. Does scleroderma affect the lungs? The answer is, yeah, definitely. What 2 things can scleroderma do to the lungs? Yeah, you guys are awesome. Pulmonary fibrosis, for sure, like interstitial lung disease. And the other thing is, yeah, pulmonary hypertension, very good. So definitely when we talk about lung disease and heart disease and scleroderma is not just about having hardening of the skin. It could affect almost every organ in the body. So she had a screening cardiopulmonary exam 3 years ago. She has GERDs. Anyone surprised the esophagus is involved in scleroderma? She has Raynaud's. She intermittently develops ulcers on the fingertips. Her current meds are calcium channel blocker and amlodipine, PPI and omeprazole, and probably some nitroglycerin ointment for those Raynaud's. On exam, she's afebrile, normotensive, non-tachy, not tachypnic. Cardiac exam reveals a loud S2 with fixed splitting. Lungs are clear to auscultation. The abdomen is unremarkable. Sclerodactyly is present, and pitting scars are visible over several fingertips, and there's no peripheral edema.